since 2011. In my confirmation as a basal implantologist, three great guys played a major role. Professor Stefan Ide from Germany, Montenegro, Dr. Henry Diederich from Luxembourg, and Professor Gerard Scortecci from France. I became acquainted with them in 2011, and since that time I was several times in Luxembourg, in Nice, in Montenegro. I became to work with IDE implant system, and I grew up to the level of opinion leader of IDE Dental and official speaker of International Implant Foundation. During last 5 years, I evolved a sort of my own concept of patient implant rehabilitation, which is a synthesis of knowledge and huge experience of three above mentioned persons. I use BCS implants very rarely. I never bent implants heads. I like to combine implants with different designs, compression screws, discs, plate shape implants, and I use a lot of combined fixation, screwing, and cementing, and to fix prosthetic device. And sometimes I load implants with metal ceramic instead of metal acrylic immediately. But today my topic is about very peculiar area of facial skeleton, so-called Tuberopterygoid area, as well about a special kind of implant, a TPG implant with screwing fixation of prosthetic device. Since I put my first Tuberopterygoid implant in Nice under supervision of Professor Scortecci, this type of implant became one of my favorite, and I obligatory use this implant if my patient need posterior maxilla rehabilitation. There is no doubt that distal maxilla is a peculiar segment of oral cavity, even in dentalist conditions, due to anatomical vicinity of maxillary sinus, visual and manual access. But if patients are losing maxillary teeth, we face other problems concerned mainly with non-adequate qualitative and quantitative characteristics of bone. I want to remind you that after loosening of upper lateral teeth, disbalance of the pressure occurs, and we have resorption of alveolar process, not only from the side of oral cavity, but also from the nasal cavity. And eventually we have an eggshell layer of bone below maxillary sinus, which is very difficult for implant rehabilitation. In 1986, Cabot and Howell from United States presented their classification of alveolar processes in distal maxilla, which included 6 classes, starting from class 1 with present of teeth, class 2, fresh post-extraction socket, class 3 with adequate qualitative and quantitative characteristics of bone S, and 3 negative classes, negative for prosthetics, class 4, class 5, and class 6, respectively blade shape, flat shape, and depression of alveolar process. Unfortunately, when Longman in 1998 investigated 300 of patients with maxillary atrophy, it was revealed that approximately 75% of our patients belongs to classes 4, 5, and 6. In other words, 75 of our patients at that time could not get implant rehabilitation without long and severe additional operations aimed to create a necessary bone volume for traditional implant placement. Historically, a wide spectrum of techniques has been offered to create better conditions for crestal implant placement. In 1970, pre-implant surgery was determined as a separate direction of maxillofacial surgery. In 1977, Bell and colleagues proposed L4-1 osteotomy with bone transplantation, which allowed them to move maxilla 1 cm down and 1 cm forward and to get some bone volume for crestal implant placement. In 1988, Wood and colleagues proposed autogenous bone transplantation. Here we have 2 techniques. We have inlay technique, when we put transplant material inside the bone, so-called sandwich technique, and we have onlay technique when we put transplant material, for example, from the crest, on the bone surface and fix it with a titanium mini plates. Zygomatic implants as an option for such patient is good. We use it a lot, but it's technically demanded and quite expensive. Among more realistic procedures on upper jaw, open sinus lift was proposed